Welcome to this deep dive. Today we're cracking open the musculoskeletal system.
Yeah, the absolute foundation of human movement structure.
And surprisingly, even things like blood formation.
Right.
This stuff is really essential for conducting a thorough, focused assessment. And our goal here is to give you the strategic shortcuts.
Exactly. Our mission isn't just like reciting anatomy facts. It's about distilling the clinical gold.
Clinical gold, I like that.
Yeah, the core connections between what a client tells you, their history.
The subjective stuff.
Right, the subjective data, and those critical, sometimes unexpected objective findings you get from the exam.
So you can spot what really matters.
We want you to be able to jump straight to what matters most for assessing function, mobility, all that.
Okay, let's unpack this then, starting exactly where we have to, right? With the fundamental anatomy and physiology. That stuff supports the entire assessment process.
Right, you got to have the foundation. Think of the MS system as a highly specialized scaffolding system. It's made up of bones, cartilage, ligaments, tendons, and muscles. Pretty straightforward components.
But if someone asks why it's vital...
then you need those 5 primary functions ready to go.
And they're really comprehensive functions, aren't they? It goes way beyond just shape and movement.
Totally. Providing shape, supporting the body, allowing movement, that's the obvious stuff.
Yeah.
But we often forget the internal maintenance roles.
Like protecting organs.
Precisely.
Yeah.
The skull protects the brain. Ribs protect the heart and lungs.
Yeah.
Basic, but critical.
And then there's hematopoiesis.
Yes. Blood cell formation happening right there in the bone marrow. That's huge.
It's a storage.
And storage, yeah. Bones are the main bank for calcium and phosphorus, essential minerals.
It's interesting, though, because during an assessment, while all 5 functions are happening, you're clinically really zoning in on support, movement, and protection, mostly.
That's a really key distinction, yeah.
Yeah.
If any of those 3 seem compromised, that immediately tells you where to focus the rest of your evaluation. Now, okay, before we move on, let's quickly clarify those connective tissues.
Yeah, ligaments versus tendons. Always trips people up.
It does. But knowing the difference is key to understanding, like, injury mechanisms.
So give us the breakdown, the connectors.
Okay. Ligaments. Think L for link.
Right.
They're tough, flexible bands of connective tissue linking bone directly to bone.
Bone to bone, got it.
Their main job is stabilization. They strengthen the joint and stop it from moving in ways it shouldn't. Think of them like the joint's seatbelt.
Okay, seatbelts and tendons.
Tendons. Think T for transmit. They're made mostly of non-elastic collagen, and they connect muscle to bone.
Muscle to bone, different connection.
Totally different. They're the active transmitters of force. Muscle contracts, tendon pulls the bone, boom, movement.
So in an injury scenario.
Exactly.
Yeah.
Knowing if you've got a ligament sprain, that means joint instability versus a tendon strain, which is impaired movement because the muscle attachment's hurt.
That immediately changes how you investigate.
Completely dictates the diagnostic path. Makes the distinction crystal clear, right?
Yeah, absolutely. And the muscles themselves, almost half our body weight.
Yep, the engines. Using those tendons to generate movement, we've got skeletal muscles for moving the skeleton.
That's one we think about.
Right. Then smooth muscles lining organs, and of course, cardiac muscle in the heart.
Okay, so that's our essential A&P review covered.
Now, before we even think about touching the client,
Section 2.
Section 2, gathering that subjective data, the health history, this is where we start forming our initial ideas, our hypotheses.
And we're not just like ticking boxes here. We're looking for functional impact.
Exactly. What's truly affecting the client's daily performance.
So you start with ADLs, activities of daily living.
That's your functional status litmus test, really. Bathing, dressing, walking, feeding, simple tasks. If the client struggles with these,
You know immediately there's a significant functional deficit.
right, then you need the details. Where exactly is the joint or muscle pain? Location matters.
And just as important as where it hurts is asking about those neurological symptoms.
Ooh, critical. Numbness, tingling, stiffness, weakness, even twitching.
Why so critical?
Because musculoskeletal complaints so often cross over into the neurological realm. These symptoms can flag things like nerve entrapment or even central nervous system issues.
Yeah.
Big red flags.
Okay. What else in the history?
We absolutely need info on risk factors and lifestyle. Any history of falls recently? Has their weight changed suddenly, up or down? Do they do high-impact sports? Or maybe, no exercise at all?
It all builds the picture.
Builds the risk profile, exactly.
Yeah.
And here's a really crucial clinical nugget,
Okay.
especially for women going through hormonal changes, like postmenopausal women.
Right.
You must ask about their maximum height, like what's the tallest they ever were
Compared to now.
compared to now. And you specifically ask about calcium or vitamin D supplements.
And why those two specifically?
Because those pieces of subjective info are the most immediate flags for osteoporosis risk.
Ah, the bone density issue.
Right. Height loss is a classic sign of vertebral compression fractures from thinning bones. So you're strategically screening for bone health right there in the mobility assessment.
Smart. Don't forget past surgeries, too.
Oh, absolutely.
Yeah.
Any past surgery on joints, muscles, ligaments, that history profoundly impacts their current range of motion and what you might expect to find.
Okay, so subjective picture is forming. Now we shift.
Now we shift to objective data. Section 3, the physical assessment approach and analyzing posture.
What's the standard approach here? Techniques, tools?
The approach is standardized and pretty straightforward. Inspection first,
Look first.
then palpation.
Feel.
We need the client to move through different positions too.
Like standing, sitting.
Standing, sitting, and supine lying flat on their back. This lets you get a good look at all the joints.
And tools. Our eyes and hands are key. But what else?
Equipment simple but essential. You need a tape measure.
For limb circumference, maybe?
Yeah, or length discrepancies.
Yeah.
A drape, obviously, for privacy. And critically, a goniometer.
Okay, the goniometer. Looks like a protractor. Why is it so critical?
It's not just a fancy protractor. It measures the angle of a joint precisely. Think degrees.
And why quantify it?
Well, imagine you suspect an evolving condition, like arthritis. You need a baseline measurement, a number for their range of motion, or ROM.
Ah, so you can track it over time.
Exactly. Track disease progression, or see if therapy is actually working. Gives you objective proof.
Makes sense. Now, the golden rule of inspection.
Symmetry. Symmetry, symmetry, symmetry. Observe and compare everything bilaterally. Joints, muscles, tissues.
Both sides of the body.
Always. If the right shoulder looks off, first thing you do, compare it to the left. Simple but powerful. And measure height too, like we said. Track it over time.
Okay, posture inspection. What's expected?
Expected finding is posture's erect, head's midline, both shoulders and hips are at equal heights bilaterally level.
And unexpected. Things we might see.
Well, particularly in the lower extremities, you might see abnormal knee positioning.
Like knock knees.
Yeah, genu valgum. That's knock knees, where the knees touch but the ankles don't.
And the opposite.
Genu verum. Bow-leggedness. Ankles might touch, but the knees are wide apart.
Okay. Now, you mentioned a critical detour here during posture assessment.
Yes, this is vital. While you're doing a routine MS assessment, you always have to be looking for signs of severe central nervous system injury.
Things that show up in posture.
Exactly. These specific postures are visual alarms for major brain injury. It's a potential life-saving check.
Okay, let's focus on those. The two severe types. Decorticate posturing first. What does that look like?
Decorticate suggests damage above the brainstem, usually cortex. Think to the core. The arms internally rotate and adduct.
Pull in towards the body.
Right, pulled in towards the core. Elbows, wrists, fingers are all flexed, curled in, and the legs are stiffly extended.
Okay, arms flexed in, legs expended. That's decorticate. And the other one, the more ominous sign.
That's decerebrate posturing. This is more serious, signaling damage deeper down in the midbrain or brainstem.
How does it look different?
Here, the arms are stiffly extended, adducted, and hyperpronated, rotated inwards.
So arms are straight and turned in, away from the core.
Exactly, extended away from the body. Legs are also stiffly extended, often with feet in plantar flexion. Recognizing these two patterns, decorticate versus decerebrate, is a critical link between a basic assessment and neurological emergency.
Wow. Okay, that really puts the critical and clinical insight. Moving on then, section 4, spine, gait, and range of motion ROM.
Right. For the spine, inspect from the side first. You're looking for that normal S-shaped curve.
Concave in the neck.
Concave cervical, convex thoracic curving out, concave lumbar curving in, and then convex sacral at the bottom.
And the key active check.
Ask the client to bend forward at the waist like they're trying to touch their toes.
Why that move?
Because it straightens the spine visually. Makes it much easier to spot abnormalities like scoliosis.
The S or C curve, side to side.
Exactly. You also look for kyphosis, that exaggerated outward hump in the upper back.
Sometimes see that in older adults.
Yeah, it's quite common, often called dowager's hump. And lordosis, which is that excessive inward swayback curve in the lower back.
Got it. So after checking static posture in the spine,
We shift to dynamic assessment, gait analysis. How do they walk?
just watch them walk across the room.
Yep. And you're inspecting everything. How do their arms swing? What's the cadence, the rhythm? How wide is their base of support? Stride length?
Even their shoes.
Absolutely. The wear pattern on their shoes tells a story about how they distribute weight over time. Uneven wear can be a clue.
Expected gait is smooth, coordinated, balanced.
Heel and toe walk, yeah. Arms swinging easily.
And unexpected findings, what do they tell us?
Oh, they're super informative. If someone's bearing weight unevenly, maybe limping, that often points straight to hip or knee pain.
Makes sense.
Then you look for ataxia. That's an unsteady, staggering, uncoordinated gait. Often indicates cerebellar issues or problems with sensory pathways.
And the shuffling gait?
Classic shuffling gait. Short steps, maybe reduced arm swing, often seen in older adults, particularly with Parkinson's disease. Tells you volumes about neurological involvement.
Okay, after gait, we get hands-on with the joints.
Right, assessing all the major ones. TMJ, the jaw, cervical spine, shoulders, elbows, wrists, fingers, then down to the hips, knees, ankles, feet, toes.
And what are we checking for at each joint?
You're looking at ROM, obviously, but also skin condition, redness, swelling, warmth, any deformity, tenderness on palpation, and stability.
And listening to.
Yes, listening and feeling for crepitus during movement.
That crunching sound or feeling.
Exactly. It's that audible and palpable crunching or grating. It's usually caused by friction, bone on bone, roughened cartilage, maybe a tendon snapping over bone.
So it means cushioning is gone or damaged.
It's a key sign something's wrong structurally within the joint.
So expected findings across all joints. Symmetry, stability, no pain.
Pretty much. Unexpected would be tenderness, weird depressions or protrusions, warmth indicating inflammation, or obviously limited ROM. Those are your red flags.
Which guide your next steps.
Exactly.
Okay, section 5. Muscle strength and connecting the dots.
Right. We combine that ROM testing with muscle strength testing.
How's that done?
Basically, you ask the client to move the joint through its range of motion while you apply resistance against that movement.
Okay. And we screen this how?
Simple screens are effective. Hand grip strength. Ask them to squeeze your fingers. Foot push against your hands like a gas pedal. Leg raise against resistance.
And always compare sides.
Always compare side to side. Critically important. And remember, the dominant side might naturally be a little bit stronger. That's normal.
But we grade the strength, right? What do those grades mean?
Yeah, we use the 0 to 5 scale. 55 is the goal. Full range of motion against full resistance. Normal strength.
And 45?
45 is full ROM against moderate resistance. Still pretty good.
But below that?
If the client rates below a 45, indicating clear weakness, that's a significant finding. It demands deeper investigation.
Because it could point to...
Could point to neurological issues like paralysis from a stroke, maybe myasthenia gravis, Guillain-Barré syndrome, something systemic affecting nerve or muscle function.
So the ultimate goal here is linking what the patient told you.
There's subjective reports, yeah.
Like pain or stiffness with what you found on the exam.
The objective findings, like limited ROM, that crepitus we talked about, or muscle weakness. That synthesis, putting subjective and objective together.
That dictates the action plan.
Precisely. Your focused assessment plan, treatment ideas, or need for further diagnostics.
Can you give an example of how that synthesis works?
Sure. It's perfectly illustrated if you contrast inflammatory arthritis with, say, a mechanical injury. Let's zero in on rheumatoid arthritis, RA.
Okay, RA.
It's a chronic inflammatory autoimmune disease. Key point. It usually affects joints symmetrically, both wrists, both knees.
And the key diagnostic nugget about the pain, how it behaves.
Yes. The pain in RA is typically worse in the morning and often worse at rest.
Worse at rest, that seems counterintuitive.
It does. But it's classic inflammatory pain. And crucially, movement often decreases the pain and stiffness, at least initially.
So moving helps.
For RA, often, yes, it eases the stiffness. This is the complete opposite of mechanical osteoarthritis, where movement usually makes the pain worse.
Big difference.
Huge difference. And you might also look for specific joint changes, like Bouchard's nodes in the finger joints. Understanding that pain timing difference is absolutely vital for making that initial differential diagnosis between inflammatory and mechanical joint problems.
Okay, that's a really clear clinical connection. Before we wrap, section 6, older adults, their assessments need special consideration. Right?
Yeah, absolutely. As we age, certain musculoskeletal changes are common, even expected. We need to factor those in.
Like what kind of changes?
You'll often see a wider base of support when they walk for better stability.
Yeah.
Increased kyphosis, that upper back curve we mentioned, is common. And height loss, often due to vertebral compression or disc changes. We also see muscle loss atrophy, which means reduced strength. ROM often becomes more limited. and just generally measurable declines in speed, reaction time, coordination.
So these are expected findings, but still important.
They're expected, but they still necessitate assessment and potentially intervention to maintain function and prevent falls.
And this brings us back full circle to the biggest risk factor here.
Osteoporosis, yeah. Loss of bone density leading to that height loss and critically increased fracture risk.
How serious is it?
It's the leading cause of bone fractures, particularly hip fractures in the elderly. And hip fractures can have devastating consequences, even be fatal.
What are the main risk factors again?
Postmenopausal status is a big one due to estrogen loss, smaller height and weight frame, lack of physical activity, especially weight-bearing exercise, and low calcium or vitamin D intake.
Which is why screening is recommended.
Yes, standardized screening, usually via bone density scan or DEXA scan, is recommended for all women 65 and older, and sometimes earlier, depending on risk factors.
So this leads directly into health promotion. What can we advise?
Our general health promotion interventions are crucial here. Teaching proper ergonomics to prevent strain, injury prevention strategies, especially around falls,
And exercise.
emphasizing weight-bearing exercise, walking, light weights, resistance bands, whatever is appropriate for the individual. That's critical for stimulating bone density.
Plus calcium and vitamin D.
Absolutely. Ensuring adequate intake through diet or supplements, and of course, reinforcing the negatives. No smoking, limit alcohol. Both impact bone health.
So health promotion is really about applying what we find in the assessment to help the client improve.
Exactly. It moves the assessment from just finding problems to actively working towards better functional health.
Oh, okay. Well, I think we successfully navigated the anatomy, the detailed history, the objective checks, all the way from spotting critical posturing down to gait and muscle grading. You really should have a complete strategic roadmap now for that musculoskeletal assessment.
Which brings us to a final thought, a question for you, the learner, to consider.
Okay.
When you're managing a client who reports significant chronic pain, let's say back pain, very subjective.
Right. They feel it intensely.
Intensely. But then their objective examination appears completely normal. Full range of motion, 55 strength everywhere, no tenderness, no crepitus, nothing objective to find.
So a big mismatch.
A big mismatch between the subjective report and the objective findings. How do you reconcile that difference? How do you formulate the most supportive and comprehensive plan for gathering more data or managing that patient when what they say and what you see don't seem to align?
That's a fantastic challenge. Really makes you think about integrating everything we've discussed. Thank you for diving deep with us today.
My pleasure.
Now go forth and apply this knowledge.